All right, let's jump right into this explainer. Today, we're zeroing in on two really common but pretty different tendinopathies, epicondylitis and Achilles tendinopathy. Our main question is simple. How do we get the diagnosis right?
So here's our game plan. First, we'll get on the same page by defining the pathology. Then, we're going to break down the diagnosis for an Achilles rupture, followed by epicondylitis. And finally, we'll tie it all together with a unified diagnostic approach. Okay, first things first. Let's make sure we've got our terminology locked down so we're all speaking the same clinical language. The most important term here is tendinopathy. Now, a lot of people might think tendinitis, inflammation, but tendinopathy is a much broader, more accurate term. We're talking about diseases of the tendon that involve degenerative changes, pain, and real functional loss, especially right at the enthesis, that critical spot where the tendon actually anchors to the bone. Okay, with that foundation, let's apply it to our first case, the Achilles tendon. This is the site of one of the most significant tendon injuries we're going to see in practice. So the worst-case scenario for a bad Achilles tendinopathy is a complete rupture. And this isn't some rare event, it's one of the most common tendon tears out there. This makes getting a fast, accurate diagnosis absolutely critical for the patient's future. So you've got a patient in front of you. You suspect a complete rupture. What's the immediate question? How do you confirm it? Right there in the clinic. What's the definitive move?
The answer is a classic, elegant physical exam maneuver, the Thompson test. A positive test here is really the cornerstone of making a clinical diagnosis for a complete Achilles tear.
The beauty of this test is its simplicity. You have the patient lie prone, feet hanging off the edge of the table. Then you, the examiner, just give the calf muscles a good squeeze. Now, if that tendon is intact, you'll see the foot passively plantar flex. It has to. But if that tendon is completely torn, the link is broken. You can squeeze that calf all day and you'll get nothing, no movement at the foot. That absence of plantar flexion, that's your positive sign. It's incredibly reliable and can often be more definitive than waiting around for imaging.
All right, let's switch gears completely. Now we're going to talk about epicondylitis. This condition is going to lead us down a totally different diagnostic path, moving away from a hands-on physical test and more towards imaging.
You see, unlike the clear mechanical yes or no of an Achilles rupture, epicondylitis is much more about seeing the chronic degenerative changes happening at the muscle-tendon attachment. We're not looking for a simple pass-fail test. We need to visualize the pathology itself. And for this kind of detective work, the tool that really shines is ultrasonography. When you're dealing with soft tissue issues like epicondylitis, ultrasound gives you the detailed look you need to really assess the tendon structure. So what makes ultrasound so great here? Well, a few key things. It's everywhere, it's way cheaper than an MRI. But the real game changer is that it allows for a dynamic exam. What does that mean? It means you can have the patient actually move their wrist while you're imaging, watching in real time for things like tendon thickening, those dark hypoechoic areas that scream degeneration, or even new blood vessel formation. You're getting live feedback on the tendon's integrity.
So let's pause and pull this all together. We've seen two different tendinopathies and two pretty different ways to get to the diagnosis. Let's synthesize this into one clear takeaway.
This table really just lays it out perfectly. For an acute Achilles rupture, your go-to is the clinical exam, hands down. It all hinges on that Thompson test. But for a chronic, degenerative condition like epicondylitis, your focus shifts to imaging, specifically ultrasonography, so you can actually see the tissue changes. And that's the big point, right? There is no one-size-fits-all diagnostic strategy. You have to tailor your approach. You need to understand the pathology you're up against to pick the right tool for the job, whether that tool is your own two hands, an ultrasound probe, or more often than not, a smart combination of both. But let's ask the ultimate question. Why do we obsess over this? Why does getting an early, accurate diagnosis matter so much in the first place? To really understand the stakes, think back to a core principle we learn in traumatology about what happens when you don't treat an injury correctly. It's a powerful lesson about what happens when we misdiagnose or just fail to act. Now, that quote is about fractures, but the principle is identical for tendinopathies. A missed Achilles rupture or a poorly managed case of epicondylitis, these things don't just magically get better. They can lead to a lifetime with chronic pain, major functional loss, and irreversible degenerative disease. So getting the diagnosis right isn't just some academic exercise. It is the absolute critical first step to preserving your patient's function and preventing long-term disability.